Hello, my name is Helen Wagster. I'm one of the registered nurses at Carolinas Medical Center. I'm also an international board certified lactation consultant, and I have been requested today to have a bit of a conversation about the anatomy and the physiology of the breast in preparation for breastfeeding. Most people do understand that breastfeeding is best, and most women can breastfeed effectively. But there are some things that can be challenges, and some of those are included in anatomy and physiology. So we're going to start with a few things to talk about the anatomy and what you need to know. Your book that you have has a great diagram of what the breast tissue is like. It is some studies that were done by Dr. Donna Geddes in Australia. And they are from ultrasounds that they had where they showed the breast ductules, the ducts, and how the anatomy of the internal breast is. That can be found on page 535 of your textbook. The breast starts developing in utero. Moms who carry little girls, their bodies are starting to have this developmental phase. It starts in that fetal period and it continues throughout with an enhancing of some of the properties that occur around adolescence. When a woman gets pregnant, other changes occur. Those changes begin generally in the beginning with the hormonal changes that the mother experiences. These hormonal changes can have her feeling some changing in the breast tissue, size, the feeling of it. Some mothers claim they feel a tingling sensation. This is an indication that those hormones are starting to work. By the time she is 16 to 20 weeks pregnant, she has already started to produce colostrum. Colostrum is going to be the first milk, so at 20 weeks, mothers have milk. At that point in time, the milk is generally not going to be released, and that has to do with one of the hormones that is involved in this process called progesterone. Progesterone inhibits the secretion of that milk so that moms don't start having a big volume of milk developing. There are other hormones that are involved in this. Some of those hormones are metabolic hormones like insulin and growth hormones, thyroid hormones. These are all going to play a part in this mother's ability to make milk. But the two key hormones that are involved in milk production are prolactin and oxytocin. The prolactin and oxytocin are going to be stimulated from the pituitary to release, and this is going to be a key piece of this development of milk for this baby. But first, moms have to have the adequate breast tissue. That breast tissue is going to start off with what's called the tail of Spence, and this is the mammary tissue that extends to the axilla. It connects to the ductal network, and it's possibly a site for the pooling of breast milk. Mastitis oftentimes will occur in this area. The size of the breast does not matter. Some mothers who are very small can have very large capacities for milk, and some mothers who are very large may have small capacities for milk. The nipple itself has anywhere between 4 and 18 openings. There are muscle fibers around these openings that help to keep the milk from leaking out and from having a continuous flow. The Montgomery's tubercles, those are sebaceous glands that are lubricating the areola. There are between 15 and 25 lobes of lactiferous ducts that are around the breast and behind the nipple. The breast is highly vascular. It supplies, the internal mammary artery supplies 60% of the blood to the breast, and the lateral thoracic artery supplies 30% of the blood to the breast. Lymphatic system, that is there to collect excess fluids from tissue space, bacteria, and cast off cell points. Breasts are classified by physical characteristics. Type 1 is a rounded breast that is normal, has a lower medial and lateral quadrant. Type 2 breast is hypoplasia of the lower medial quadrant. Type 3 is hypoplasia of the lower medial and lateral quadrants. And a type 4 is severe constrictions with minimal base breast tissue. The further that the breast tissue is from each side, the less breast tissue that's available for milk production. One of the rules that lactation consultants go by is if you can place 4 fingers between the breast tissue on either side between the 2 breasts, you're going to start to have problems with an adequate milk supply. There are different types of nipples. We have the common nipple, which most people have, and that's usually an elongated nipple that's sometimes short, sometimes long. A flat or a short shanked nipple. These can be a little bit challenging for babies to latch onto. A pseudo-inverted nipple. So this can be a nipple that appears inverted, but when there is any kind of stimulation, it elongates out. A retracted nipple, and this is the most common type of inverted nipple. When you grasp it, it will retract with stimulation. So as it is touched in what we call the pinch test, it will retract back. And an inverted nipple which stays retract at rest, and it is with stimulation retracted. You can also see different unusual nipple situations like a bulbous, which is a large nipple, a dimpled nipple, a bifurcated, double or multiple nipples close together, and skin tags. And these oftentimes will show themselves during pregnancy. When the placenta is delivered, that releases the progesterone hold on the milk production. This is the beginning part of lactogenesis 2. When that hormone allows the milk to come out. This is one of the reasons why we want to see babies having a latch and a feeding within 1 hour of delivery, because the body is primed for the milk, with the milk having collected since about 20 weeks gestation, and it's easily released with the baby at the breast. This continues to be lactogenesis 2 for a few days with frequent stimulation of the breast and with removal of the milk, whether it's with the baby removing the milk, hand expression, or pumping. The frequency is what's important. Once that mature milk is there, anywhere between 3 to 5 days after delivery for a vaginal delivery and 4 to 6 days for a C-section, it becomes lactogenesis 3. Lactogenesis 3 is where the body is creating the amount of milk that the baby is taking and the mother is requesting. So if a mother is breastfeeding the baby and pumping, what is removed is what is mother's going to make the next time. This continues throughout the entire time that this mother is breastfeeding. During lactogenesis 2, prolactin is released frequently and there are high blood levels. When you get to lactogenesis 3, there is a drop in the amount of prolactin that is being secreted. It's no longer a hormonal driven process, but an autocratic process. Hang on, I'll get that word right. An autocrine control. It's an autocrine control process. So what's removed is what is made, and it's not hormone driven any longer, though the mother will have a release of some prolactin during this time. Oxytocin is one of the hormones that is key for helping with milk production. During lactogenesis 2, its responsibility is to help to squeeze the areola around the milk lobules to be able to get the milk out. So with the baby having a good suction at the breast and frequency at the breast, the oxytocin helps to do let down or push milk out. Early frequent feedings help to stimulate this milk production, and it's critical for this time frame. Mothers during the pregnancy have a higher level of prolactin at night, which is oftentimes why babies want to feed frequently at night. Babies have been getting this communication over a period of months prior to delivery, so they frequently will feed at night. This also is a setup for what is called lactational amenorrhea, and mothers who have frequent feedings at night will frequently not have a lactational episode until amenorrhea, another period as long as the baby is breastfeeding well at night. There are some things that can delay lactogenesis too. It can be delayed by an overload of fluid during the labor. The mother's health status, if the mother has had any critical situations that occurred during the labor or the delivery. Women with type 1 diabetes have a harder time getting a milk supply well established. It can take up to 7 days for them to get a good milk supply. And with retained placental fragments, as long as there is some releasing of that progesterone from placental fragments, the mother's milk supply will be struggling to occur. Let's see, what else do I want to talk to you about? Skin to skin is an extremely important part after the labor and the delivery because this helps to stimulate milk production along with the prolactin and the oxytocin release. When mothers are having a hard time with babies being sleepy in the first 24 hours, the skin to skin time is what helps to release those hormones and keep those blood levels high. For a mother who has had breast surgery, such as a reduction or a augmentation, there can be challenges for this mother to have a successful milk production. Generally, if the augmentation is done beneath the muscle, then she has less problems with the milk production, but she can have some issues with engorgement because of the implant that's in place. Reductions tend to be a lot more challenging, and they may not see much, if any, of a milk production. There is no way that you can tell from a mother to a mother how many of the milk ducts have been disrupted, if that ductal route has a way out, if there is going to be a situation where this mother will experience severe engorgement. Frequently they will have engorgement. Some mothers are dedicated to this process and are willing to suffer through 5 to 6 weeks of engorgement in order to get a milk supply for their baby. Each mother is different on this. The goal is to try to help her to have realistic expectations and to know what it is that she wants to do and what is possible to happen. 60% of women who have had breast surgery will not make enough milk for their baby. They can make some, but not necessarily enough. If a mother has a disruption in any one of those metabolic hormones, if she has problems with thyroid, hypo or hyperthyroid, if she has insulin requirements for her diabetes, these are all situations that can cause a lower milk supply.